A special welcome to our council members and to the NINR science community. Good morning to everyone. We are continuing with virtual meetings this round. As you can see, this meeting is being videocast live and will be archived on the NIH Videocast website. So again, thank you for joining us online this morning. So before we begin with the meeting's agenda, I'll take a moment to introduce Dr. Elizabeth Tarlov. Dr. Tarlov recently joined NINR as the director of our Division of Extramural Science Programs. She will also serve as the council's executive secretary. Elizabeth comes to us from the University of Illinois, Chicago and the U.S. Department of Veterans Affairs. She has a long-standing interest in and commitment to research on social determinants of health. Her program of research has integrated individual, institutional, and community-level data to identify impacts of policy and the environment on adult health and behaviors, healthcare outcomes, and health inequities. As an innovator of record linkages, Elizabeth's research program creatively leveraged the vast data resources of the VA in combination with the external public and proprietary data sources to obtain new insights into contextual influences on health and healthcare effectiveness. She's also conducted methodological work focused on derivation of valid measures of individual social and economic characteristics from raw administrative data. Prior to launching her research career, Dr. Tarlov practiced as a family nurse practitioner in urban and rural community health centers, a staff model HMO, and a student health center. So we are so excited to have Elizabeth's expertise and her experience here at NINR. Yes, indeed. Thank you. Welcome, Elizabeth. So now we'll give her a turn. So to help ensure quorum for this meeting, Dr. Tarlov will do roll call. Elizabeth.
Good morning and welcome. I will now do a roll call to ensure we have a quorum for today's meeting. Please say present or here when I call your name. Dr. Atkins. Is Dr. Atkins here? Mr. Dawes.
Present.
Dr. Fitzpatrick.
Present.
Dr. Holmbeck.
Present.
Dr. Johnson.
Present, and welcome, Elizabeth.
Thank you, Dr. Johnson. Dr. Lee.
Present, and welcome, Elizabeth.
Dr. Lewin.
Present.
Dr. Lowe.
Present.
Dr. Monroe.
Present.
Dr. Provencia Vasquez. Dr. Stone.
Present and welcome.
Thank you. Dr. Wolf.
Present.
And Dr. Sullivan as ex officio.
Present.
Dr. Zank, a quorum for this meeting has been met.
Excellent, thank you. So with that, let's jump right in and go over a few of the logistics for the day. Just a reminder to please mute yourself when you're not speaking to eliminate background noise for our guests. This is a one-day meeting only. Closed session will begin following the end of open session. A separate meeting invitation was sent to council members and all applicable staff with login instructions for the closed session. Several ad hoc council members were introduced at our January meeting. So today, I am pleased to announce that Dr. Atkins, Professor Dawes, Dr. Fitzpatrick, and Dr. Stone are joining us today as full council members. So welcome to each. It's wonderful to have you with us, and we are so grateful for your service. Looking forward to the next few years together. So as always, a video from the January Advisory Council meeting is available at the address shown on the slide. Minutes of the meeting from January were made available to you in the electronic council book for your review. So may I have a motion to approve?
Go ahead.
I saw Dr. Stone, but I'm not sure who else. So I'll go with Dr. Stone. How about a second?
Second.
Thank you, Chris. Any discussion? Okay, any opposed? Okay, thank you. So the motion carries. So dates for the future council meetings are listed in the NINR council webpage, as well as in the open session materials in the electronic council book. So please do add those to your calendar. So there's a number of dates already scheduled. Our next meeting is September 13th, and we'll follow up with council to discuss the format of the next meeting, given the ever-changing situation with the pandemic. I do want to remind you that as special government employees, council members may not engage in lobbying activities while receiving pay from the federal government. Further information regarding conflict of interest and confidentiality requirements are posted in the electronic council book, so please review those if you haven't already. Dr. Tarlov will be giving more specific instructions about conflict of interest and confidentiality at the beginning of the closed session later this afternoon. So now we'll just move right into my director's report, and I have a number of things to tell you about. So I am thrilled to share that we launched our 2022-2026 strategic plan earlier this month on Friday, May 6th, the first day of National Nurses Week. I gave an overview of the broad strokes of that plan at our January council meeting, and I'm happy to provide a quick refresher and share a few details about how we finalized the plan. So our mission statement reflects our belief that nursing research is the key to unlocking the power and potential of nursing. At NINR, we're committed to leading nursing science to solve pressing health challenges and inform practice and policy, optimizing health and advancing health equity into the future. Our strategic plan describes how we want to leverage the strengths and unique knowledge and perspective inherent to the discipline to the benefit of all people. The strategic plan includes guiding principles, that is, important qualities that all NINR supported work should have going forward. In considering grant applications for funding, the extent to which studies reflect these principles will be a factor in our decisions. We need to support research that addresses today's challenges and helps us be better prepared for the future. Discover solutions to optimize health across clinical, community, and policy settings. Advances equity, diversity, inclusion, and accessibility, and is innovative, applies rigorous research methods, and has the potential for significant impact on health and well-being. In developing our scientific strategy, NINR identified 5 lenses that we think best leverage the strengths of nursing science to innovate, think bigger, and greatly increase our impact. The lenses in the strategic plan are health equity, social determinants of health, population and community health, prevention and health promotion, and systems and models of care. For each of the lenses, we've provided details in the plan about what the lens means to NINR and what research through that lens looks like. These research lenses are complementary and synergistic. In addition to leveraging the strengths of nursing science, the lenses promote multi-level approaches, cross-disciplinary and cross-sectoral collaboration, and community engagement in research. As shown in our research framework graphic, NINR-supported investigators have the flexibility to apply a single lens or a combination of lenses in their study designs and training programs. We encourage researchers to view the health equity and social determinants of health lenses as primary foci through which to consider the other lenses. NINR's research lenses will allow investigators to consider a full spectrum of nursing research topics that encompass health and illness within the context of people's lived experiences. Thus, the lenses will allow nurse scientists and nursing scientists to examine new topics, while also allowing those with long-standing programs of research to take a different look at their areas of interest. Many of the lenses build on NINR's investment in long-standing areas of interest. For example, 43% of NINR's budget already supports prevention research. 34% of the budget focuses on research to eliminate health disparities. And 26% of NINR's budget focuses on social determinants of health. So you can find the full strategic plan on our website. Please consider this a living document, which we'll use to respond quickly and nimbly to emerging issues or crises. So as a result of this, our belief that it should be a living document, we believed it was best housed on our website. So you can always find the latest version there. So next, I'll share an update on our budget. After operating for the first part of fiscal year 2022 on a continuing resolution, in March, Congress passed a full-year omnibus spending bill, which funds us through September 30th of this year. For fiscal year 22, we received $180 million, which was a 3.4% increase over last fiscal year. The NIH received a 5.2% increase, including funding for ARPA-H. So now I'd like to share information about the President's budget request for fiscal year 23. As I'm reviewing these numbers, do keep in mind that for fiscal year 22, that continuing resolution was used as the base for the fiscal year 23 President's budget request, because NIH did not yet have a fiscal year 22 appropriation. So the fiscal year 2023 NINR's presidential budget request is $199 million. This is an increase of 13.6%, or just under $24 million. 20 million of which is for health disparities research. This is part of an overall $400 million increase in health disparities research proposed for fiscal year 23 across several institutes and centers, the majority of which is going to the National Institute on Minority Health and Health Disparities. The NIH fiscal year 23 President's budget request for fiscal year 23 is $62.5 billion, an increase of $19.6 billion, which is a 45.6% increase over the fiscal year 22 continuing resolution. This increase includes over $12 billion for pandemic preparedness and $5 billion for ARPA-H. So you can find more information on the President's budget request at the NIH Office of Budget website. So now I'll give an update on our Division of Extramural Science programs. Since January, NINR grants were cited for over 500 articles in PubMed, and several papers based on NINR-supported research have recently been published that align with the research lenses in our new strategic plan. So here are a couple of examples. One study from authors including Council member Dr. Ann Fitzpatrick examined hotspots of pediatric intensive care unit readmissions and hospital lengths of stay due to asthma using a geospatial analysis. They found neighborhoods with higher social vulnerability and lower childhood opportunity were associated with PICU readmissions, as well as longer duration of hospital stay and inpatient bed days. This study demonstrates that understanding the context in which a child lives can help identify those most at risk for critical asthma hospital readmissions. and can lead to interventions to address social determinants of health. Second, results of a pilot study of ENABLE Cornerstone were also recently published. Now, ENABLE stands for Educate, Nurture, Advise Before Life Ends, and is a lay navigator-led telehealth intervention for rural and African American family caregivers of individuals living with a newly diagnosed advanced cancer. In this randomized trial, researchers found that when compared to the usual care group, caregiver distress and quality of life improved significantly in the intervention group. This intervention targets historically underserved caregivers, a very important population, and we certainly look forward to seeing results from the full-scale trial. I want to highlight some of the funding opportunity announcements, or FOAs, that we've signed on to since January Council. These include a FOA for the FIRST program, which aims to facilitate institutions in building a self-reinforcing community of scientists committed to inclusive excellence. Applications are now being accepted for the new cohort. Another is a limited competition FOA for minority serving institutions for the Transformative Health Disparities Program that NINR is co-chairing and which I've discussed at prior council meetings. And there's two more FOAs to support dissemination and implementation research. So here are some of the notices of special interest, or NOCIs, in which we are participating and have signed on to since January Council as well. These are focused on validation of digital health and AI tools, translational research on preventive screening services, and women's health research in the IDEA states. So we hope that you will check these out as well. And I am pleased to report that we received robust responses to our NINR-led funding opportunity announcements on maternal health outcomes and food and housing policies related to COVID. Applications are currently under review, and we will update you on research supported through these announcements at an upcoming council meeting. I would also like to draw your attention to a new page on our website. This provides information on our fiscal year 22 funding strategy. Now, we posted this information to help those interested in applying for NINR funding to understand what our priorities are, as well as our strategies for maximizing our limited resources. So I encourage you all to check out the information on our website. And as always, please reach out to program directors if you have any questions. So now, some updates from our Division of Intramural Research. Please join me in congratulating NINR Graduate Partnerships Program Fellow, Dr. Stephanie H.E.A.L. In April, she successfully defended her dissertation, Liquid Biopsies for Type 2 Diabetes Mellitus, Biomarkers for Disease Risk and Diagnosis. So Dr. H.E.A.L is a fellow in the lab of Dr. Polly Joseph, who has a primary appointment at NIAAA and a secondary appointment here at NINR. She will soon start an iCure postdoctoral fellowship at NCI. So we are all excited about her accomplishment and look forward to following her research into the future. So congratulations again, Stephanie. I'm also proud to share just a few of the recent publications of our intramural scientists at NINR. Dr. Leo Saligan and colleagues published an exploration of the relationship between mitochondrial DNA gene expression and fatigue in breast cancer survivors who were enrolled in a clinical trial involving fish and soybean oil dietary supplementation. The study observed that baseline mitochondrial DNA gene expression predicted improvements in fatigue over a 6-week period of fatty acid supplementation. And NLM Director Dr. Patty Brennan, whose lab is housed at NINR, published on the development of design requirements for immersive virtual reality environments to support people in their home in self-care. Dr. Brennan and colleagues conducted and analyzed key informant interviews with expert home care nurses to identify challenges that could be addressed using immersive virtual reality. Based on the findings, they developed design requirements for 2 virtual reality environments: a grocery store simulation to aid food selection appropriate for a restricted diet, and a kitchen simulation to aid patients managing a complex medication regime. In another recent paper, Dr. Tokes Lawal and colleagues demonstrated an automated protocol for quantification of intramuscular fatty infiltration in the lower extremity muscles of individuals with RYR1 related myopathy using T1 weighted MRI. They also examined the relationships of intramuscular fatty infiltration with motor function and clinical severity. And Dr. Polly Joseph and colleagues recently published based on data from a global study involving more than 60 countries. Sudden smell loss, as we know, is a specific early symptom of COVID-19, which prior to the emergence of Omicron had an estimated prevalence of about 40 to 75%. So the aim of this analysis was to characterize smell function and recovery up to 11 months post-COVID-19 infection. They found that while smellability improves for many individuals who lost it during acute COVID-19, the prevalence of parosmia and phantosmia increases substantially over time. So olfactory dysfunction is associated with broader persistent symptoms of COVID-19 and may last many months following acute COVID-19. So that's our update from Intramural. So now I'm going to turn to a few updates on our commitment to diversity and inclusion at NINR. You may recall that in January, Council formed 2 working groups to explore diversity and inclusion in the studies we support and in our scientific workforce. So I do want to thank the co-chairs and members of both committees for their participation and certainly appreciate the progress they've made so far. I look forward to their updates on their activities at today's meetings and to reviewing the full working group reports, which are currently slated for completion by September's council meeting. I also want to recognize the working groups for being part of the leading edge of diversity and inclusion efforts for NINR and for NIH as a whole. Just recently, NIH was recognized as a leader in diversity and inclusion during a NACNR webinar titled Improving Representation in Clinical Trials and Research, Building Research Equity for Women and Underrepresented Groups. One of NINR's trainees was part of the NACNR committee that developed that report. Additionally, the NIH Chief Officer for Scientific Workforce Diversity recently sponsored a seminar entitled, How Does Diversity Impact Science? So my understanding is that this seminar was very much aligned with topics that the NINR Workforce Diversity Group will present on later today. And I'd like to remind everyone that NINR supports diversity supplements to enhance the diversity of the research and entrepreneurial workforces by recruiting and supporting students, postdoctoral fellows, and eligible investigators from diverse backgrounds. This includes those from groups that have been shown to be underrepresented in health-related research or in the small business programs. So we encourage all of our funded investigators to consider applying for these supplements to ensure that our work is inclusive of everyone. Diversity supplements have been shown to help launch successful and productive research careers for scientists of diverse backgrounds. Moreover, in our recent funding opportunity announcements, NINR began requiring a diversity and inclusion plan for our funded research to advance the scientific and technical merits of the proposed project through expanded inclusivity. We also notify applicants that this plan and how it will strengthen the project will be considered in the review process. In addition, our fiscal year 22 funding strategy indicates that we will consider advancement of diverse perspectives in addition to priority score, strategic priorities, and inclusion of early stage investigators in our funding decisions. And finally, I want to share with you that NINR is currently seeking a scientific diversity officer. The candidate will be responsible for providing scientific leadership and direction for all diversity requirements and initiatives related to the planning, development, implementation, and evaluation of our research. This position was advertised earlier this spring, and we're currently reviewing potential candidates. So I look forward to updating you when we've made a selection for that position. As you know, collaboration is vital for furthering nursing research, and I am thrilled that the contributions of NINR and nursing science are increasingly recognized across NIH and HHS. We are making sure that NINR is at the table and leading efforts to collaborate with partners both within NIH and across the federal government. So I'll share some updates on our partnerships and collaborations. Recognizing the urgency of health equity research, NINR, along with our colleagues from several NIH institutes and offices, is co-chairing a new 10-year, $397 million NIH Common Fund program called COMPASS. Now, as background, NIH Common Fund programs address emerging scientific opportunities and pressing challenges in biomedical research that no single NIH institute or center can address on its own, but are of high priority for the NIH as a whole. The Common Fund really is a unique resource at NIH where high-risk, innovative endeavors with the potential for extraordinary impact are supported. We believe that COMPASS will be transformative and help us to make real progress in eliminating health inequities and ultimately achieving health equity by looking upstream at the systems and structures that are causing socially and economically disadvantaged populations to become sick in the first place. The program has two overarching goals. First, the program will facilitate and implement a cross-institute and center framework for health equity intervention research. Second, it will deploy and evaluate community-driven structural health equity interventions that leverage intersectoral partnerships. So you can find information about the program at the provided address, and more information will be available in the coming months. We are also pleased to announce the launch of a new NIH-wide Social Determinants of Health Research Coordinating Committee. We are co-chairing this committee together with the National Institute on Minority Health and Health Disparities and the Office of Behavioral and Social Sciences Research. And we've been joined by 13 other institutes, centers, and offices as well. Now, the goal of the Social Determinants of Health Research Coordinating Committee is to accelerate this field of research across NIH. This includes across diseases and conditions, across populations, stages of the life course, and social determinants of health domains. The idea of the Research Coordinating Committee grew out of interests of staff colleagues across NIH, and we are very proud to be helping to lead this NIH-wide effort. So since January Council, we have joined two new federal efforts. First, we joined a new Social Determinants of Health Interagency Policy Committee as the NIH representative. The goals of this committee are to support a federal framework for coordinated care and service delivery model to address social determinants of health, and to develop a White House action plan sharing guidance and potential policy levers to address social determinants of health. We are also the NIH representative to the HHS initiative to strengthen primary health care. As such, NIR is coordinating NIH's response in this area. This initiative grew out of the NACNR report, Implementing High Quality Primary Care, with the goal of building a federal foundation to support primary health care for our nation that will provide high quality primary health care for all improve the health of individuals, families, and communities, and advance health equity. So it will culminate in an action plan to strengthen primary health care. So we are also very proud to be representing NIH in both of these federal collaborations. So now I'll turn to a few updates from NINR outside of our strategic plan. Last month, I co-authored with Acting NIH Director, Dr. Tabak, and NIMHD Director, Dr. Perez Estable, a viewpoint published in JAMA on research opportunities to address nutrition insecurity and disparities. In 2021, an estimated 42 million Americans, including 13 million children, lacked adequate access to food, disproportionately affecting African American and Latinx communities. So in the viewpoint, we discussed challenges like these and potential opportunities to address diet-related health disparities through research. This coming year, we'll be hosting a series of webinars led by science, practice, and policy experts focused on each of the strategic plan research lenses. Now, two of the main goals of the lectures are to inform nursing scientists of the possibilities for research under the new lenses and to provide a forum for discussion on how NINR-supported research can help inform practice and policy. So I am excited to announce that Dr. Vincent Guillermo Ramos, Dean of the Duke University School of Nursing, will present our first lecture of the year on July 12th. Dean Ramos will present his thoughts on nursing research priorities within the social determinants of health lens. He'll also discuss the practice and policy implications of nursing research through this lens. So I hope that you will join us at this virtual meeting, and we'll post more information on our website as soon as it's available. I am also excited to tell you that we are working on rebranding our NINR look and feel. We will release the rebranding later this summer, so look forward to that. We are. And as you know, searches are ongoing for several key leadership positions. We look forward to updating you on those searches at upcoming meetings. But while we continue our search for the next permanent deputy director, I am so pleased that Dr. John Grayson officially stepped into the acting deputy role in February. Dr. Grayson has served in NINR's Division of Science Policy and Public Liaison for more than 16 years, most recently serving as acting director of this division. He began his NIH career as a science policy analyst in the division, having joined NIH from the HHS Emerging Leaders Fellowship Program in 2005. He has a PhD in biochemistry from the University of Maryland, College Park. He has been instrumental in NINR's strategic planning process, as well as many other initiatives across the Institute. And he has been a source of very wise counsel to me and to leaders across NINR. So I am so delighted to be partnering with John in this important role, and am very thankful for his service. We've welcomed several additional colleagues across the Institute since January. Michelle Mitchell joined us this week as NINR's Legislative Affairs Officer. Eddie Boutsadi is a new IT support staffer. Ashley Irick joined as a budget analyst this week, and Wendy Pond is our new ethics coordinator. Dr. Sue Martin has come to NINR as our acting Division of Extramural Science Programs Deputy Director. She is on detail from NICHD, and we are fortunate to have her expertise as well. And we have several staff to welcome to our intramural program as well. Dr. Stephen Gonzalez is a staff scientist working with senior investigator Dr. Leo Saligan, and just this week, 2 baccalaureate fellows joined NINR, Catherine Quat and Christopher Nguyen. So welcome to all our new NINR colleagues. We are, though, looking for additional nursing scientists to join our team. So one exciting opportunity to join is as a program officer. In this role, you'll have the opportunity to help shape NINR's research portfolio to support the strongest, highest impact science with the greatest potential to solve our nation's most pressing health challenges. This is an exciting opportunity and time to join NINR and contribute to implementing our new vision and strategic direction. Program officers stimulate, plan, direct, and evaluate activities for a portfolio of research projects, research program and other grants and awards, cooperative agreements, and contracts. So we are specifically interested in expertise aligned with the new strategic plan. These positions are filled via NIH's Global Health Science Administrator job announcement. A new announcement was posted on May 16th. There's still time. The applications are due tomorrow. But if you can't make that, our next global announcement will be posted in September. So you'll find the announcement on USA Jobs and at the NIH link that you see here. You can also feel free to reach out to our Extramural Director, Dr. Tarlov, with questions as well. And a few NIH updates before I end my director's presentation. So first, I am so excited to share that NIH has returned to our physical workplace. At NINR, we celebrated with welcome back parties for each of our divisions, and I was so happy to meet many of our staff in person for the very first time. And I look forward to future meetings where I hope to be able to meet many of you in person as well. There is of 14 NIH institutes, centers, and offices co-funding a NACNR consensus study on the use of race, ethnicity, and ancestry as population descriptors in genomics research. The committee is charged with reviewing and assessing the existing methodologies, benefits, and challenges in the use of race and ethnicity and other population descriptors in genomics research. Now, part of the charge for this committee is to assess and develop approaches to advance appropriate use of race, ethnicity, and genetic ancestry. The committee hopes to hear from researchers, advocates, and any other interested stakeholders with comments by Wednesday, June 1st, and will invite selected authors to present their comments at a public workshop on June 14th. I also want to draw your attention to a recently released NIH resource from the NIH Office of Science Policy and Office of Extramural Research. This resource is to help protect privacy and respect the autonomy of research participants when sharing data. This resource provides sample language for investigators and IRBs when developing consent for secondary use of data and biospecimens. So we hope that the extramural community finds this resource to be helpful in their work. The Office of Extramural Research also released a request for comment on protecting the privacy of research participants when data are shared. NIH is seeking comments on this draft guidance through June 27th. And we encourage you to share these resources broadly with your internal and external communities. Here is an update on ARPA-H. The draft mission of this program is to benefit the health of all Americans by catalyzing health breakthroughs that cannot readily be accomplished through traditional research or commercial activity. And it's that last part that's a key point. Doing things that can't be done currently. It will support transformative, high-risk, high-reward biomedical and health research to embrace a sense of urgency to speed application and implementation of breakthroughs at various levels, from molecular to societal, so that they serve all people. Build capabilities and platforms that are broadly applicable across a range of diseases and conditions to revolutionize how we prevent, treat, and cure them. Focus on converting use-driven ideas, those ideas with a direct application, into solutions for patients quickly, and help to overcome market failures through creative solutions, incentives, and de-risking. So ARPA-H will leverage an approach that was pioneered at DARPA. ARPA-H is being created as a distinct and bold entity within NIH that will have the autonomy, independence, resources, and authorities to tackle some of the biggest challenges facing human health. ARPA-H will draw on knowledge, expertise, and ongoing activities of NIH, maximizing scientific collaboration and synergy, and minimizing duplication of scientific and administrative effort. Its current status is that the fiscal year 22 omnibus appropriated $1 billion to be available over 3 years to launch ARPA-H. So we should have more information on this agency in the coming months. So thank you, everyone, again, for all that you've contributed to NINR's accomplishments and for providing your expertise in support of our goals for the years ahead. NIH, NINR, and I value your contributions to the Institute. So thank you for bringing your perspectives across so many vital fields of research to NINR. Your guidance on our research and its impact are invaluable. And I just have to thank our NINR team, especially Joanne Kriebel, Joni Dawson, Dr. Rebecca Hawes, and Dr. Timura for all their work compiling data for this report. It's a lot. So with that, we'll transition to our next agenda item, but I'll pause first and to see if there's any questions or comments related to the director's report.
So, Dr. Zank, I'd like to just start out by thanking you for your leadership. This was extremely exciting to hear and see, and especially when you talked about the primary foci of health equity and the social determinants of health, and what you all are doing to co-chair the NIH-wide SDOH coordinating committee. So kudos to you all. I think this is really exciting because we are getting to the root causes, as they were, the poor health outcomes, and you're looking at the drivers of these health inequities. So I'm excited to see that. Was really excited because, you know, at the grassroots level, many of us, you know, in academia really have been struggling to figure out who's doing what. And it seems to me that you're going to be able to help us figure out, okay, this is where folks are focusing on in terms of SDOH research. Here's where we can actually contribute in that effort. And I appreciate that you're leading that effort. So thank you, and to the entire team.
Thank you. We appreciate that. Yeah, a number of people at NINR are working really hard, including Shalonda Bynum, who is on. So yeah, it's really a big effort across the NIH. So thank you. Other questions or comments? Okay. All right, thank you. So we will transition then. As I mentioned during the September council meeting, we identified that nursing science and NINR need to do better in supporting a diverse scientific workforce and increasing inclusion in our studies of those populations that bear a disproportionate burden of disease and risk. In January of this year, I announced the formation of 2 working groups. The work group on strategies to enhance diversity in the NINR-supported nursing science workforce, which is co-chaired by Dr. Christopher Lee of Council and NINR's Dr. Shalonda Bynum, as well as a work group on strategies to strengthen inclusion in NINR-supported research, co-chaired by Dr. Cindy Monroe and NINR's Dr. Dion Godet-Greer. So these working groups have been working diligently over the past few months, and today will update us on their progress. So I will turn it over to Drs. Lee and Monroe for the updates, and starting, I believe, with an introduction by Dr. Bynum. So I'll hand it off.
Thank you for the introduction of these very important working groups, Dr. Zink. So good afternoon to you all. Again, my name is Shalonda Bynum. I am a program director at NINR, and I co-chair the working group on diversity. I am very pleased to be with you today as we share the interim report from these groups. So we will begin with a presentation on workforce diversity, followed by inclusion. We ask that you hold your questions until the end of both presentations. We will allow time for comments, thoughts, and questions at that time. Next slide. Next slide, please. Okay. So I want to start by saying the views discussed today are those of the working groups and do not necessarily represent the views of NINR or the NIH. Next slide, please. So you have seen this slide earlier, so it will serve really as a refresher. So we want, what you see here are the principles that guide NINR supported research. And I want to draw your attention to the third bullet as it serves as the guiding force for these working groups. Next slide. So within the context of NINR guiding principles and the broader NIH discussion around diversity and inclusion, these working groups were formed to identify innovative and proximal strategies to address the long-standing issues of underrepresentation and who gets funded and who are enrolled in the studies that we fund. So our hope is that the efforts of these working groups and those to come in the future will advance NINR's demonstrated commitment in these areas. Next slide. So both working groups use the same overarching structure to guide discussions, answering the questions of what, why, what, and how. So the why is diversity and inclusion an issue and a topic that requires attention at NINR? The what can be done to address barriers to advancing diversity and inclusion? And finally, the how might NINR implement recommended strategies to advance in this space? Next slide. So the deliverable from these efforts is to provide NINR counsel and NINR leadership a set of strategies, actionable strategies that can be moved forward to advance diversity and inclusion. To accomplish this, we've had a total of 4 meetings, which bring us to today, the interim report phase. And we have 4 remaining meetings, which will bring us to the final report stage. And with that, I will turn it over to my co-chair, Dr. Lee, to lead us through the workforce diversity interim report. Dr. Lee?
Yeah, thank you very much. I really appreciate it. And council colleagues and members of the NINR community, it's really our privilege to share with you our progress to date. Just another shout out to my wonderful colleague, Dr. Shalana Bynum, and the great privilege it is to help lead this working group on diversity in the NINR supported scientific workforce. Next slide, please. The charge of the working group really involves these 2 related tenets. First, to provide advice to this council on effective strategies to enhance the diversity of the NINR supported nursing science workforce. And second, to really provide recommendations for improving success rates for groups that are underrepresented nationally in or historically excluded from biomedical and health research who apply for NINR grant and training funding. We happily have accepted this charge and have been working diligently both during and in between our scheduled sessions. Next slide, please. Dr. Bynum and I have a great pleasure of working with this wonderful, insightful, and generous group of colleagues who are more than willing to share with us their expertise and their experience. The role of the working group is really to collaboratively develop ideas in response to our charge. And Dr. Bynum and I really facilitate and support the work of the group, but our role largely is to really relay the message back to you on their behalf. Next slide, please. In addition to what was described earlier as a framework for the work of our group, we have been focusing on the scope of the problem, prioritizing barriers and developing strategies to address them, shaping and vetting actionable strategies, and positioning implementation strategies. And just like the framework that was presented earlier, our process has been more iterative than it has been linear in our best effort to make sure that we get this job right. Next slide, please. So data on NINR supported workforce, such as these, have been shared with council previously, but I do want to just take a minute to briefly recap some of that information as a reminder of how important our work is. So here is presented the racial makeup of principal investigators of NINR supported R-level grants during the time range of fiscal years 2015 through 2019. You can see that of the NINR supported R-level PIs during that time, 75.6 identified as being white, and in contrast, only 4.3% identified as being Black or African American. We know from benchmarking data on both science and engineering PhD graduates and from PhD nursing graduates from the same time frame that, as an example, Black and African American investigators are significantly underrepresented as principal investigators on R-level grants supported by NINR. We greatly appreciate that NINR has shared this with us, and we acknowledge as well that these numbers are unacceptable. Next slide, please. Here is the racial and ethnic makeup of trainees on NINR supported K, T, and F series grants during that same time frame of fiscal years 2015 through fiscal year 2019. You can see that, for example, 68%, 75%, and 70.8% of K, T, and F trainees supported by NINR respectively identified as being white. In contrast, you can see that 4%, 11.4%, and 12.3% of K, T, and F trainees supported by NINR respectively identified as being Black or African American during that time frame. You can see that 4%, 9.1%, and 6.4% of KAT and F trainees supported by NINR respectively, again during that time, identified as being Hispanic. And then finally, you can see that during this time period, there were no trainees who identified as being American Indian, Alaska Native, Native Hawaiian, or Pacific Islander supported by any NINR, KAT, or F. Again, we are so grateful that NINR is willing to share this information with us. And again, we acknowledge that these numbers are unacceptable. These and other similar data have really served as a major motivation for the work of our group. Next slide, please. So a large part of our process has involved posing open-ended questions to the members of our working group. We started with questions about barriers internal to NINR and NIH more broadly, factors external to NINR, NIH, and factors outside of NIH completely contributing to funding disparities by race and ethnicity. Responses were then grouped into categories and presented back to the working group for comment and discussion. And then finally, we followed up meetings with brief surveys to optimize input from our group. Many of the identified barriers are consistent with existing knowledge base around these topics, but some are new and really specific to NINR. Next slide, please. Here are some barriers identified by the working group that are viewed to be internal to NINR, NIH. For example, the NINR focal areas may not resonate with diverse researchers, and a caveat of that being that our discussion took place prior to the release of NINR's new strategic plan and the new research lenses. NIH diversity and funding opportunity announcements are viewed to be quite limiting and only partially leveraged. The competitive nature of training programs limits opportunities for lower resourced institutions and investigators, such as minority serving institutions in general and historically Black colleges and universities in particular. Issues with scientific review, including the lack of diversity on review groups, lack of understanding of review, and lack of understanding of methods used by diverse researchers are additional barriers to success. Next slide, please. Here are some factors identified by the working group that are viewed to be external to NINR and NIH. First, there is a degree of unawareness of NINR's areas of interest, now research lenses. Second, many potential PIs have multiple competing demands on their time and or limited time and resources needed to have successful applications. Third, many potential PIs have limited support and even a sense of belonging in their current academic settings. Fourth, infrastructure to support grant submissions and management may be quite limited, especially at minority serving institutions. And then finally, mentorship has come up frequently in our group conversations around the dearth of engaged scientific mentorship for potential PIs and or competing demands and expectations put on potential mentors that therefore further limit the potential pool. Next slide, please. Next slide, please. Thank you. Here are barriers identified by the working group that are viewed to contribute to funding disparities. First, unfair review and funding outcomes as a function of race and ethnicity. The potential applicant pool itself may be quite limited. The issue of scientific mentoring, again, surfaced during these conversations. And then finally, concerns were raised about insufficient institutional resources to support grant submissions. Under each one of these categories and discussion of specific barriers, we have been having robust conversations about what can be done. Next slide, please. Over the next 4 meetings, we will begin working to match actionable strategies with identified barriers and, of course, prioritizing them. We will take into consideration, of course, the pragmatics of suggested strategies on what would be most feasible for NINR to implement. And our final report to Council, again, will take place during our September meeting, so I really look forward to being able to present to my colleagues once again. And at this point, I'll turn the presentation over to Dr. Cindy Monroe, co-chair of the Working Group on Strategies to Strengthen Inclusion in NINR-supported research.
Thank you, Dr. Lee. Our work group is the companion work group here, looking at strategies that could be used to strengthen participant inclusion in NINR-supported research. Next slide, please. So this is the working group charge for the inclusion work group. And we really did focus, we are focusing on the factors that may influence participant inclusion in supported studies. Some of those factors include the PI and the research team expertise, the research topic itself, the design of the study, how inclusion and exclusion criteria are formulated and used, what recruitment strategies are used, and also what policies and practices are in place at NINR that influences participant inclusion. Next slide, please. So our work group is charged with making suggestions to Council to consider for actions that NINR can take to increase diversity and inclusion. And in order to accomplish that charge, the group that has been assembled is a very representative group, working group. It includes members from nursing administration, from academia, including nursing science and public health. Representatives from the community are included, including faith-based organizations. We have current NINR Council members, representatives from healthcare systems, a co-chair in our NINR Extramural program, official co-chair, and a liaison from the NINR Office of Science, Policy, and Legislation. And I would like to take a moment to really thank the work group for the wonderful, deep, and insightful conversations that we have had to date, and for their dedication to finding solutions to improve the problem of participant inclusion. Next slide, please. We set the stage for our inclusion work group with particular guardrails in place. So there are many issues related to diversity, equity, and inclusion. The focus for us were really related to the things which NIH is focused most tightly on at this point, related to their legislative mandates. So the first is the NIH Revitalization Act of 1993, which really set the stage saying that women must be included as subjects, and that members of minority groups should be included or must be included in such research as well. And that set the mandated enrollment data requirements for reporting by sex, gender, race, and ethnicity. And so the data which we have available is in part available because of the NIH Revitalization Act of 1993. The second piece of legislation is the 21st Century Cures Act, which was enacted in 2016, and it requires inclusion reporting from all institutes and centers, including NINR, and then to also require that clinical trials submit results of analyses by sex, gender, race, and ethnicity in clinicaltrials.gov. So these two really have formed the basis of the data which are reportable and discoverable in NIH and in the NINR system. There's also a new piece in 2019, inclusion across the lifespan, which said that individuals of all ages, including children and older adults, must be included in human subjects research. And so unless there is a scientific or an ethical reason not to include them. And so the reporting of age, and that as an entity that we can look at, is a little bit newer in terms of what data were available for the work group to work with. Next slide, please. So the work group began with a data review of sort of what is the state of the science here at NINR, and we looked at NINR funded institutions, at the investigators that are funded by NINR, and at the participant data that is available within the guardrails that we have available. We looked at the diversity and inclusion of research participants and compared the NINR data to NIH data to get a better sense of where representation is falling short at NINR. And we looked at who is conducting the research that is supported by NINR. We also took a dive into the NINR support of health disparities research, minority health focused research, and or rural health studies looking at other disadvantaged populations. And then we also did a deep dive on what funding collaborations NINR has engaged in with other institutes to get a sense of what work is being done collaboratively as well as focused only in NINR. And then we also, across the meetings that we have shared published resources on participant inclusion in health research, as well as looking at guidelines of journals and other data points that could help to both identify the issues and to help us to identify actionable strategies. Next slide, please. As we did our work, we focused our work on what were the multi-level determinants of inclusion. So taking our charge and looking at the range of factors, we came up with three groups that are sort of the levels of determinants of inclusion. The first being the level at the participant, where those factors that are related directly to obstacles to participation of individuals in clinical research or other clinical research design, non-clinical research design. The second level of determinants of inclusion that we looked at were those factors that are related to the investigator. So what kinds of investigator obstacles are there to inclusion of diverse study participants? For example, things like the trial design, the selection of sites, the understanding of the NIH inclusion policy. And then the third level that we identified was structural and institutional factors, which includes things like policies and resources that can shape the way that investigators and participants engage in research that is funded by NINR. Next slide, please. So we then moved on, as Dr. Lee said, not in a linear pattern, but in an iterative pattern to look at what were barriers to inclusion based on these three levels of participant, investigator, and structural organizational factors. This list of barriers that is presented in the diagram is not a comprehensive list of what's been discussed in the work group. It really is just exemplars that we're bringing forth to show that we really are looking at each of these levels of engagement. For example, at the participant level, lack of trust is one item that, or one factor that we looked at, and then resources to provide for childcare or time off to participate in research. In the investigator site, the ability to have time to relationship build and engage with community partners, or to select sites that focus in disadvantaged communities where the diversity and inclusion could be a richer engagement. At the level of structural and organization, there is the question about, for example, what are the investments in the community, and what are the investments and relationship building with community partners that could be strengthened in structural or organizational ways. So next slide. Again, moving on somewhat organically, as we were discussing the barriers to inclusion, we have also been looking at what would be some ways to promote inclusion, understanding those barriers. And again, this is based on data and on work group member expertise. It is really just a snapshot meant to provide some exemplars of the rich discussion that's happened in the work group. So for example, in the participant section, if we have an opportunity to fund community organizations, that would enable us to build trust with participants who use those organizations or are part of that community. At the investigator level, looking at training or other mechanisms to make sure that the study team is prepared to recruit and retain people from diverse populations. Use of a community connector or community liaisons has also been discussed. And then in the structural and organizational thing, there are some of the things that we've talked about in terms of inclusion are broadening out the sites in which research is conducted, for example, using multi-site designs. We did think that, and we've talked a great deal about how the grant review process might promote inclusion at the structural or organizational level, with greater scoring weight for diverse inclusion plans, with longer study timelines, with the ability to supplement early investigators or to allow for pre-recruitment engagement stages to build more trust in the community and more trust with participants. Again, these are really just exemplars of the very rich discussion that has been taking place in the work group to this point at our interim report. And for the next slide, these are our next steps. The first is to select some priority barriers that we think would be the most important ways in which barriers to overcome that would move the needle the most, and to select recommended strategies that could happen, that NINR could implement that would help to overcome those barriers. And then as we select strategies to move forward for consideration by Council and by NINR, we're really focusing on what might be accomplished in the near term. That is, what easy or quick wins could we get in the first 6 to 12 months that would improve the situation? What could happen in the next 24 months? And then what could happen by the end of the current NINR strategic planning period by 2026? We're also looking carefully at how might the strategies be evaluated and what metrics should be used to see whether we are making progress or whether we are meeting the goals that are set. Next slide. We also are using a very similar strategy in terms of our next steps. First of all, articulating the why. And you remember that was the first step for each of the working groups. The second, where we are right now, is prioritizing concerns and focusing on the feasible action strategies. And prior to our next report to council in September, we'll be developing the final reported recommendations from the work group. So at next slide, we're all four of us co-chairs are going to take questions on either of the work groups at this point.
I have a question, Stat Stone. First of all, great work. So thank you all for all the work you're doing. That was very, very interesting. And I appreciated in the diversity group that you compared some of the work to what other all of NIH, because one of my questions for Chris is, although it's not really, I guess if everybody's doing poorly, we shouldn't say that, okay, we're just doing this poorly, it's somebody else. But it is sort of nice to know how NINR is doing compared to the other institutes. But one of the things I thought about was other, race and ethnicity is what you were thinking about for diversity. We know that males are, not enough males in nursing, as well as sexual and gender minorities and other diverse groups. Are we thinking about those at all?
Yeah, thanks, Pat. Fabulous question, as always. And, we were charged to think about diversity quite broadly, although we did have to undergo some prioritization based on the data that are available for the group to review. And, this group saw that the most glaring inequities did tend to lead in the direction of race and ethnicity. And in the process, we thought if we started there, then we would identify potential strategies that would work in other aspects of diversity as well. So the preponderance of information that we had available to us, again, very grateful of the full transparency of the institutes, both NINR and then broadly at NIH for sharing this information and allowing us to share it with you as well. But the preponderance of it is actually focused on the egregious inequities that still exist in race and ethnicity. So as a starting place there, but with the hope, again, that as the strategies that we come up with are going to have some universality and how they can help other disadvantaged groups. Then John, I see your hand up, Ben.
Thank you for that information, and that was very rich information and in depth, and really speaks to the great work that you've done, and it's very appreciated. I was struck by and interested in the inclusion of diverse investigators, and it sounds what was presented, and I can and I know moving forward you're going to be working on the strategies to address these issues, and it seems like internally to NINR and NIH there's been a lot of work done to move and to address the inclusion of diverse investigators. I think my a little bit maybe concerning and maybe challenging will be the external factors and how that will be addressed. And, they're kind of mutually exclusive, but yet they really are dependent on each other for, to address that issue. And so just wanted to make, get your response to where you might see those strategies or how you will approach addressing that strategies to address those two issues. Thank you.
Yeah, so great question again, John. I appreciate that. One of the wonderful parts of having an iterative process is we oftentimes circle back to those external barriers because that is certainly a place of great concern and maybe of less actionability without other types of strategic partnerships with organizations outside of NIH. Certainly, we've had a lot of discussion there. Actually, we're still not off the discussion of external factors quite yet. And again, we keep coming back to it. So I hope that when we report out on September, John, that you'll see that a lot of our energies and expertise is really focused on being as creative as possible and not really being bound with too many guardrails on this to think quite creatively about what can potentially be done. Any other questions or comments? And then Cindy, feel free to jump in if you have thoughts on the topic as well.
And I will say that the two work groups are very intricately connected in terms of the strategies. We have worked in our separate work groups, but I do know that one of the things that we have talked a lot about are external factors related to the investigators who are conducting the work, and so they're very related topics, and the investigator, the diversity of the workforce has a direct impact on the inclusivity for participants as well. So it's been an incredibly iterative process, and our work group is clearly still working very hard.
Any other questions or comments right now? Well, I am very grateful, all of us at NINR are for all your work. It's really important to us, and so we appreciate everything, all your investments of time and expertise to this. So looking forward to your reports in September and learning what more we can do in this space. So thank you again. So we are now at a time for a break, a lunch break, or depending on what coast you're in, it might be a breakfast break. So our next agenda item is scheduled to start the speaker at noon Eastern. So why don't we, to make sure she's available, Dr. Baker, we plan to reconvene then. So have a longer lunch or breakfast break to enjoy. So we will see you here at, I'm sorry?
1 p.m. Eastern.
Oh. Boy, all these time zones, I get confused. Thank you, Elizabeth. So we will reconvene at 1 p.m. Eastern, 12 Central, and the list goes on for our next agenda item. So see you all then. Thank you. Welcome back, everyone. So I would like to introduce our first guest speaker for today, Dr. Rebecca Baker. Dr. Baker is the director of the Helping to End Addiction Long-Term Initiative, or the NIH-H.E.A.L initiative, which is in the NIH Office of the Director. Dr. Baker leads coordination of the NIH-H.E.A.L initiative, programmatic activities between the Office of the Director and relevant institutes and centers. She helped develop the NIH-H.E.A.L initiative, working closely with NIH and IC leadership. And she also provides expert advice to and represents the NIH director on initiative-related activities, including interagency efforts in pain and opioid research and policy. So I will turn it over to Dr. Baker as she gives us an overview of the H.E.A.L initiative. Welcome, Dr. Baker.
Thank you so much, Dr. Zank, and thank you for the opportunity to share an update with the NINR Council. It's terrific to be with you here today. So next slide, please. As you all know, the national crisis of opioid misuse, overdose, and untreated pain is rapidly evolving and continues to devastate communities across the country. So this slide shows you just a little bit of history starting in the 1980s and in the 1990s, over-reliance on opioid medications for pain management led to increases in opioid misuse, addiction, and overdose. And in the years in the 2000s, we saw the arrival of heroin and illicit opioids, fueling the overdose crisis and increasing awareness of the risks of opioids. All of this together led to a dramatic rise in opioid prescriptions, but not necessarily a dramatic improvement in how people were experiencing their pain and how pain was managed. Then, as the crisis got to the really significantly devastating place that it is now, with the arrival of cheap synthetic opioids such as fentanyl driving record overdose death rates across the country, we started to see more awareness of the risks of opioid prescriptions for medication, for pain management, a decrease in in opioid prescription, and still no appreciable difference or improvement in pain management, and tragically, a continued increase in opioid overdoses and overdose deaths. So this is really a complicated crisis and a rapidly moving target that we in the biomedical research community are seeking to address through scientific solutions. And so that brings me to my next slide, the goals of the NINR. And then pain is still a huge unmet need, with millions of Americans experiencing chronic pain, severe pain, and pain that's so high impact that they can't go about important things in their life, family, work, other things that give their life meaning. So next slide, please. This brings me to the H.E.A.L initiative. At this point, this initiative was launched in 2018, and we've now funded over $2 billion worth of research, over 600 different projects, and over 30 programs. This research is underway in all 50 states, and it serves a lot of different evidence needs. So we have prevention research, research to develop new treatments, basic and translational science, a large number of clinical trials testing what works best for different pain conditions, different contexts of treating opioid use disorder, and then a significant investment in implementation science, where we take the evidence-based interventions that we already have, that we already know work, and we seek to bring them into settings where people come seeking help. So community settings, justice settings, and other places where research isn't always conducted. This chart on the right shows a little bit about, just gives you a snapshot of how we organize the activities of the initiative. On the top, the overarching goal of enhancing pain management through both preclinical and clinical research. And then on the bottom, improving treatments and outcomes for people with opioid misuse and addiction, including research on novel medications, affected newborns exposed to opioids during a mother's pregnancy, new prevention and treatment strategies, and then lastly, translating research into practice. So in the next slide, I give a brief overview of what that means from the research perspective. In the area of novel therapeutic options, we are seeking to complement the 3 FDA-approved and really life-saving medications that currently exist for opioid use disorder, with additional, more user-friendly candidate therapeutics. So a person might not need to take medication every day, but every week or every month instead. And also medications or therapeutics that would address other parts of addiction, for instance, craving, relapse, and some of the associated health conditions that put a person at risk of overdose. For these goals, we've now launched over programs with over 50 compounds that we're testing, leading to over 20 INDs filed with the FDA, so significant progress. In the area of enhanced outcomes for infants and children, we have research underway both to test the best ways of assessing the consequences of opioid exposure in the NICU, so either some of the traditional methods versus the eat, sleep, console method for assessing how severe a baby's symptoms are while also promoting bonding with mom and reducing time in the hospital, but then also tracking long-term consequences of opioid exposure over the course of child development. And then in the new prevention and treatment program, we have research working to optimize care for both opioid use disorder treatment as well as mental health conditions and mental health care, especially in primary care and non-specialty settings, focusing on prevention at-risk groups. We know who's at greatest risk for developing addiction and overdose, and so how can we target our interventions to them? And then lastly, some tools, ways of using prescription records and other EHR to detect high-risk opioid use patterns and give clinicians opportunities for early intervention. Lastly, in translating research into practice, we have a terrific group of studies. I can't do them all justice, but recognizing that one intervention is not necessarily enough, building partnerships with providers and caregivers and first responders and librarians, giving them information about what's evidence-based for treating addiction and preventing overdose, and working in those justice, community, and other settings where people come seeking help. In the next slide, I talk about our investments in pain. So in the preclinical space, we have almost like a small drug company level of investment in new targets, validation of existing targets, studying of different lead candidates and compounds that could be used for treating pain, accelerating the overall translational pipeline through screening and testing platforms, tissue chips, and optimization of candidate drugs, and then team-based research frameworks working to kind of increase our community of knowledgeable and expert scientists working to develop new treatments for pain. And then in the clinical space where the Institute has a lot of investment, we work to try to give information to clinicians about what works best for different types of patients and in different types of pain conditions and in different settings. So that includes research testing new non-opioid medications and interventions, so a substantial investment in things like cognitive behavioral therapy or pain self-management and coping skills, clinical trials of new pain therapies that are coming out of that preclinical and translational pipeline, and then different ways of managing pain together with other health conditions, including opioid use disorder. And although these trials are now underway, we're seeing very promising signs and a lot of encouragement that we'll get that information needed to reduce unnecessary opioid use and also give the people who experience pain better options for managing it and improving function in the long term. So next slide, please. I won't spend too much time here, but we are working across all of these domains to shed light in these different areas. We have a new research program focused on treating pain among people with substance use disorder who often suffer from fragmented healthcare systems. We have research underway to understand what treatments work best for infants exposed to opioids, a number of programs testing new therapeutic candidates that are moving forward to the FDA, management approaches for pain to guide clinical practice, for instance, after a surgical procedure or for musculoskeletal pain, and then lastly, research products either targeted to judges or probate courts or firemen or different people in our broader community, helping them translate the research findings coming out of the initiative into usable evidence and practice-based solutions. So next slide, please. This is a very data-rich slide or image-rich slide that seeks to depict all of the pain research programs within H.E.A.L in one place. And I think it's helpful to kind of ask some of the questions or state some of the questions that our research is trying to answer. How can we accelerate the time that it takes to bring about these urgently needed new therapeutics for treating pain? what additional tools can we use to accelerate those options. Some of that is like a screening approach or animal models. Some of it is the use of biomarkers and endpoints in the clinical studies that we're working on already. We have, with the NIH Common Fund, a very ambitious program to assess who's likely to develop common pain after common procedures like total knee replacement. We have safety testing for new drugs, effectiveness trials that test which therapies work best and for whom. And then we have pragmatic and implementation studies that really work in the healthcare setting or operate in the healthcare setting to find out what works best for real people and in real world settings. So next slide, please. A few specific places where the H.E.A.L initiative investment connects with the research community at NINR. We have research to identify effective interventions and pain management strategies that aim to reduce reliance on opioids. We have research on functional health outcomes, including ways of asking patients what research outcomes matter to them and also measuring them in the context of our trials. We have research addressing the continuum from acute to chronic pain, both in the context of pain alone and also in the other health conditions in which it often comes along, in screening for both chronic pain and also substance use disorder, opioid use disorder, and risky opioid use. A significant investment in health equity research and how inequitable access to high quality care for pain and addiction contribute to the current crisis, and a increasing appreciation of how listening to the voices of those with lived experience can enrich our research, not just in getting participants recruited into studies, but also the design, conduct, and dissemination of the research findings. So next slide, please. We also have a number of specific programs that I alluded to earlier in the pain clinical research focus area, including programs focused on back pain, focused on effectiveness research, including effectiveness of non-pharmacological research, pain management strategies, the pragmatic and implementation studies, all focused on complementary and integrative approaches to managing pain, a creative research program in the National Institute of Diabetes and, NADDK, focusing on pain associated with end-stage renal disease and among individuals who undergo hemodialysis, who often are prescribed very high amounts of opioids. And then lastly, recovery-focused integrative pain management and treatment for opioid use disorder. So in the next slide, I share a little bit about what we're doing to advance health equity through the NIH.E.A.L initiative. We have launched specific FOAs that are now at the point of about to make new awards, focused on how could pain management be addressed specifically through the equity lens, and how could contributors to unequal access to high quality pain care be addressed directly through research. We have social determinants of health, or behavioral health, program that seeks to understand all of the different contributors, including those shown here in this image: social and community, neighborhood, healthcare, education, and economic stability, how those all contribute to risks for behavioral health conditions, including mental health and also substance use disorder. And a new program that we are building now focused on coordinated pain care in healthcare systems and how equity can be included into medical systems and healthcare systems and the way we treat pain there. Next slide, please. I should also say Dr. Zenk is a terrific leader in working with us as we develop these, as is her team. And then in the training space, this is an area where H.E.A.L just has a lot of work to do. I think with all of the new funding opportunities and research projects that we're launching, we need a workforce and a united group of individuals with different areas of expertise to help us generate all of this information and insight for patients, caregivers, and clinicians. And so we're building a national consortium of mentors, scholars, and institutions. We're putting forward a lot of different types of training awards so people at different career phases can get involved in research, and specifically in pain and substance use disorder research. We have innovator awards for high-risk, high-reward research, perhaps coming from non-traditional investigators, and then a number of specific programs where we hope to draw either people from the pharmacology field or the healthcare field into research and broaden our community in those dimensions as well. So next slide, please. This is a snapshot of how the research programs underway align with the overall HHS, or Health and Human Services Overdose Prevention Strategy. Some of the areas of focus specifically outlined in that strategy include the need for care coordination and collaboration, a focus on health equity, a focus on data and data-driven research, which I'll tell you about in a moment, inclusion of harm reduction and recovery research, as well as ongoing emphasis on evidence-based treatment and preventing overdoses. So here are all of the different H.E.A.L initiative programs that fall into these different areas. And then in the next slide, you can see what we have planned for the coming year. Open funding opportunities that are posted on our website, so please check that out. Next slide, please. And where we hope to go in 23. So we have a special place on the NIH Initiative website that you can see here that lists these concepts for which FOAs are being developed right now. Important for this group, or of particular importance, would be pain management in rural communities, which is an effort being led by NINR scientists, as well as multi-level interventions for patients on long-term opioid therapy. Someone might be on high dose or long-term opioids and be currently dependent on it. What do we do with those patients? How can we best provide them safe care while not taking them off opioids that they currently need? And then ongoing and increasing investment in the areas I just told you about. So please stay tuned for more research coming through in these spaces. And then in the next slide, and that's just what our website looks like, but you can see that when you go there. Next slide. It's really important, and I know that there are many of you who will be interested in how the emerging data from the NIH initiative will inform practice and improve some of the challenges that we've been facing in giving people high quality pain care and preventing some of the risks of opioids. And so we're currently creating a H.E.A.L data ecosystem or knowledge base for the research findings coming out of the initiative that will be sources of new lines of inquiry and new scientific solutions to the opioid crisis, including who's likely to develop chronic pain after surgery, who's likely to respond best to different non-pharmacological treatments, how can we identify people who are at significantly increased risk, particularly through the use of electronic health records, but also take some looks at ourselves. How can provider bias or sources of stigma be redressed through these systems? And how can we integrate more different types of data? So not just scoring someone's pain from 1 to 10, but people's qualitative information about how they are experiencing pain, imaging, other assessments that can depict the psychosocial context in which pain is experienced and help that drive our research forward as well. Next slide, please. This is the overarching view of the H.E.A.L data ecosystem with our near-term goals to make the data generated through the initiative accessible, our ongoing goals of building our community of investigators and giving them access to these data, and also building a place where it can be fun and easy. And so we're not just requiring investigators to share data, but really giving them tools to ask questions that heretofore they were not equipped to ask or didn't have the tools or data to interrogate. So next slide, please. We recently published a JAMA article that goes into some of the things that I told you about today, but the cross-cutting themes involve integrating pain, opioid use disorder, substance use disorder, and mental health into multiple different complementary studies and not keeping them in silos, addressing health equity directly, including through partnership with people with lived experience and creative uses of data. Next slide, please. And this is our annual report where you can also read more about that. Next slide, please. I also have to call out the tremendous work that's being done by the H.E.A.L Community Partner Committee. This is a group of really superlative individuals who advise the NIH.E.A.L initiative and the H.E.A.L Executive Committee that Dr. Zeng sits on issues faced by individuals affected by pain and addiction, help us prioritize and drive forward our research in a way that is meaningful to patients, advocates, family members, and those affected by pain and addiction. Next slide, please. And we're always interested in hearing from people beyond our narrow NIH community. So I'm very pleased to have the opportunity to answer any questions you may have and either engage with you on social media or contact us anytime. Thank you.
Thank you so much, Rebecca. So good. I thought I saw a hand already. That's great. So Dr. Johnson, we've asked to lead discussion. So Dr. Johnson, are you ready?
Sure. Hi, Rebecca. Mallory Johnson from the University of California, San Francisco. This was it was great to see this overview and to learn more about this program, which I was aware of, but not as well as I am now. So it's great to learn more about it, and just really impressive how broad and comprehensive the various levels that you're focusing on. And I was particularly impressed with the weaving the emphasis on health equity and reducing health disparities. I also, everything from the basic science level to the implementation science and the structural and policy level focus. It really was really impressive. And a couple of reactions and comments that I had as I was listening and as I looked at your slides previously. One of the things that of course comes up is how COVID-19 has not only affected everything, but also just shown a light on what existing problems there are. And I think in particular in the area of substance use disorders and opioid use disorders. And so I just wonder how much the initiative has learned from, has been agile to and responsive to what we're learning with COVID-19. And I'll just throw these out there, and then you can ignore the ones that you don't want. Another thing is you mentioned briefly stigma in one of the slides, and so I thought I was looking for more about that. So the role of stigma for substance use disorders and other co-occurring factors that also come with stigma, whether it's poverty, racism, and other factors. And just so wanted to, there's more of a hope that the focus on stigma in both its sort of etiology of substance use disorders as well as the perpetuation and maintenance of substance use problems is kept front and center. And then finally, also, I was happy to see that the connections with the different training opportunities. And I wasn't sure, I am presuming, and maybe we could hear a little bit more about whether how those mechanisms are being leveraged to increase diversity in the scientific workforce focused on substance use disorders, opioid use disorders, and all of the work that you've just described. So I'll stop there. I had other ideas, but I don't want to. I've already monopolized my time with probably more questions than you have time to answer. But again, thank you for that wonderful overview and bringing us up to date.
Well, thank you for such terrific questions. I'll try to answer them in order and try to be brief so there's time for another question or two. But starting with COVID-19, I mean, that changed everything, right? It changed, how we're meeting today. It changed how our researchers conduct their science. It also changed the experiences of the people that we serve and also the trends of the crisis that we're trying to address. So it really, I was heartened to see incredible ingenuity and creativity on the part of the research community. They really did not want to stop their studies. They found ways to recruit patients virtually. They found ways to adapt their protocols to the COVID environment. And so I think we will generate a lot of interesting information about how the different, not in person, whether it be telemedicine or virtual or other types of interventions, can be valuable for different health conditions, patient populations. I think that at the same time, though, we're also experiencing just how dramatically the COVID-19 pandemic affected people. And so substance use went way up, mental health challenges went way up. And so the kind of context into which we're doing our research really changed too. Maybe some of it's an appreciation, as you say, and maybe some of it is really a big change in just how people's lives are being led in the COVID environment. I think that that's going to make it really hard for us to have, end addiction long term, but hopefully with the strength of our science, we can give those on the ground more tools and more evidence-based tools to tackle the national crisis we're facing. And then moving on to stigma, I mean, that it's another really cross-cutting issue. People with pain experience stigma, people with a substance use disorder experience stigma, people who care for those types of individuals are stigmatized in a clinical setting. And then in a lot of situations, the individual herself or the recovery community kind of recapitulates that stigma. And so our research is really trying to address all of these different levels. And so the research is underway now, but at least is bringing it into pretty clear focus and also building on some prior research in different communities. And to your last point, I mean, the training and workforce, I feel this very acutely. I don't know if it's faced by everyone in the same way, but we need the people to be doing this research and they're not there. So we have to train them. And that means bringing them in from different fields, and it means accessing them earlier in their educational path. I find that both the populations who apply to those applications are more diverse, and also the ideas that they have are more diverse, and so that just strengthens us overall. But it's a continued effort, so please do share the opportunities with your community so that we can keep getting those good applications. We fund as many as we can.
Are there other questions or comments? No. Dr. Stone, I see you highlighted. I thought maybe I saw your hand earlier, but I don't know if that was.
I was trying to clap and my hand went up.
Oh. Well, that's what it was, that flash of a hand. Very good.
I had a follow-up practical question if nobody else, if I'm not taking from someone else. So with all the different funding opportunities, it was unclear to me how much is NINR co-sponsoring these, or are these all nested within other institutes or centralized, or how can NINR from a funder perspective be involved, or are we already involved?
I'll start and maybe others from NINR can jump in too. So all of the funding, like the appropriation from Congress for H.E.A.L, goes to two NIH institutes and centers, National Institute of Drug Abuse and the National Institute of Neurological Disorders and Stroke. And then we in the Office of the Director work to find all of the right kind of scientific opportunities to direct those resources towards. And so we coordinate the development of writing of FOAs that oftentimes multiple different institutes and centers, including NINR, will sign on to and contribute their scientific expertise and their staff expertise to run if application in that focus area is successful and is awarded. But in terms of how and the kind of the scientific perspective, I defer to Dr. Zink and her team.
Sure. Thanks, Rebecca. So we do sit on the executive committee, and then we have representatives, and specifically Dr. H.E.A.L, who will be coming up, who contribute to guiding the efforts and the science under H.E.A.L. And one of the ways which Dr. H.E.A.L will highlight is we can propose concepts to H.E.A.L that, today we'll be talking about one of those concepts. So that's a specific way that we can contribute to H.E.A.L as well. But Dr. H.E.A.L will be talking more about that in just a bit. Rebecca, is there anything you want to add to that, or?
Well, the only addition I'd make is that we recognize that addiction and pain are really large and cross-cutting issues, and so we can't address them effectively with just one or two institutes of centers or one or two scientific leaders. We really need all hands on deck, so to speak, and so that's why we have this somewhat complicated structure, and also why we really seek to bring in the expertise of this community and the various different NIH communities, because it won't be done by just a few people or groups alone. So thank you for your partnership in that.
Yeah, it really is the trans NIH effort, and a big job of Rebecca and her team to coordinate, and so many institutes and centers involved. So it's quite an effort. But as Rebecca's talk has highlighted, it's a significant problem that we're taking very seriously. So, any other comments or questions for Dr. Baker before we let her go to get on with her business of H.E.A.L and everything else? Okay, thank you so much, Rebecca. Really appreciate that, and thank you, Mallory, for your comments.
Thank you for the opportunity. Bye.
Bye. So then we will transition to Dr. H.E.A.L. So next up is a presentation of a concept related to H.E.A.L for your consideration. And for that, I'll turn it over to Elizabeth, and she'll turn it over to Karen. Thanks.
Thanks, Shannon. As you recall, a concept is an early planning stage in the development of a research initiative, like a program announcement, or request for applications, or a request for proposals. NINR staff, sometimes working with colleagues from other NIH institutes, centers, or offices, develop concepts for presentation to this council for review, comment, and approval. Once we receive council input, a concept is published on our website to alert researchers to potential future funding opportunities, although not all concepts develop into formal initiatives. Today, NINR Program Director, Dr. Karen H.E.A.L, will present a concept that matches up nicely with the discussion on H.E.A.L that we just finished. Dr. H.E.A.L, the floor is yours.
Thank you very much, Dr. Tarlov, and thank you to the council and to Dr. Zeng for allowing me to present this concept today, which is a H.E.A.L initiative on chronic pain management in rural populations. And this is sponsored by NINR and co-sponsored by the National Center for Complementary and Integrative Health. So, rural and remote communities have been particularly hard hit by the opioid epidemic and are disproportionately impacted by opioid-related overdose. For example, in 2017, of the 15 counties in the United States with the highest opioid prescribing rates, 14 of them were considered rural. As these graphics from the U.S. Department of Health and Human Services show, retail opioid sales, Medicare opioid prescriptions, and drug overdose deaths are all higher in rural communities. Yet patients with chronic pain are present in all geographic areas, and recent evidence indicates that the percentage of adults with chronic pain increases as the place of residence becomes more rural, from about 16.4% in large central metro areas to about 28% in rural and remote areas. There's also an increase in high impact chronic pain as rurality increases. Furthermore, there are significant health challenges in rural areas that affect treatment of chronic and recurrent pain, including a larger percentage of adults over 65, a higher poverty rate, a lower per capita income, and a higher prevalence of adults with multiple chronic conditions. There are also greater challenges in access to adequate health care. We also know that rural and remote residents are more likely to be prescribed opioid analgesics for pain management and are less likely to use self-management interventions, thanks to an NINR-funded study by Dr. Durenbaugh and her team. In rural and remote settings, primary care providers, which includes physicians, physician assistants, nurse practitioners, clinical nurse specialists, and certified nurse midwives, are responsible for managing patients' chronic pain and for adhering to guidelines to reduce opioid use, often with very limited resources. While there are effective, evidence-based, non-opioid interventions for chronic pain, they've not been widely implemented in rural and remote areas. There's a need for a coordinated approach to identify and reduce the barriers and accelerate implementation of evidence-based non-opioid pain care in rural populations in order to optimize health, address disparities, and advance health equity. The purpose of this initiative is to accelerate implementation of evidence-based non-opioid interventions for chronic pain management in rural and remote populations. So on this map, that would be all of those areas shaded from tan to orange to brown to address the disparities in these populations. This initiative focuses on implementation in community settings and building partnerships between investigators, local providers, and community organizations. This would be a UG3, UH3 phased cooperative agreement. So a cooperative agreement allows for increased programmatic involvement throughout the period of the award. The UG3 phase would be milestone driven and focused on identifying barriers to implementation and to determining and addressing the preferences of patients and providers in the community regarding implementation of an intervention. To accomplish this, a key feature of this initiative is building community partnerships. In addition to naming a healthcare system or organizational partner in the application, during the UG3 phase, investigators will build one or more community partnerships, which may be with community organizations, faith-based organizations, local independent practitioners, libraries, schools, and so forth. And finally, investigators will have the option of piloting the intervention in that setting in the UG3 phase. If projects meet their UG3 milestones, they may progress to the UH3 implementation phase. As Dr. Baker explained, this is a H.E.A.L initiative, so funding would come from H.E.A.L, and the plan is for $5.7 million in funding in fiscal year 23 and a total of $48.9 million over the next 5 years. This concept has been reviewed and approved by the H.E.A.L Executive Committee and Multidisciplinary Working Group, and it's now being presented for your feedback as the Council of the Sponsoring Institute. This initiative would require that the participants or the grantees would be included in the pragmatic and implementation studies for the management of pain to reduce opioid prescribing, or PRISM Coordinating Center, which is one of those centers that Dr. Baker mentioned in her slides. This is part of the NIH Pragmatic Trials Collaboratory. You may remember Dr. Helene Langevin in January presented on the Pragmatic Trials Collaboratory. Involvement with PRISM and the collaboratory will give the investigators access to collaboratory expertise and tools. They will be included in collaboratory work groups on biostatistics and study design, healthcare systems interactions, community engagement, patient-centered outcomes, and ethic and regulatory issues. We have seen with other studies that it really increases the support and the probability of success, both of transitioning from the UG3 to the UH3 phase and for successful completion of the study. There has been a lot of interest in this initiative from other institutes and centers. In addition to NCCIH, who's co-sponsoring the initiative, we have confirmed interest from several ICs, including the National Cancer Institute, the National Institute on Aging, the National Institute on Dental and Craniofacial Research, the National Institute of Arthritis, Musculoskeletal and Skin Diseases, and more. So the research interest for this is focused on pragmatic implementation or hybrid effectiveness implementation studies. And projects will need to have at least one healthcare system or organizational partner. It would include a planning phase where that community partner would be identified for implementation, and plans for sustainability of the intervention beyond the period of award would need to be part of the plan. We would encourage multi-level interventions and systemic implementation strategies, and encourage utilization of existing resources like the CTSAs, practice-based research networks, federally qualified health centers, and others. Some examples of what may come in for research and of some of the settings we're interested in. We would be looking at interventions in rural or remote healthcare settings, including primary care, which might include offices, clinics, urgent care, acute care settings, including emergency rooms, hospitals, surgical centers, and in-home healthcare, and any other settings where pain management occurs. Examples of a couple of topics might be interventions that address a gap in access to non-opioid pain management. Addressing social determinants of health that affect access would be critical for this topic. Studies might include use of mobile vans, traveling to communities, telehealth solutions, or decision support tools for patients and primary providers. We're also interested in interventions that address health equity and decision-making for pain assessment, management, and follow-up. Studies to address social determinants of health that affect implementation of these guidelines are also of interest. And studies testing the effectiveness of implementation strategies to reduce disparities and improve quality of chronic pain management among those who are both rural and who are part of a racial or ethnic minority, low literacy or numeracy groups, who are under or uninsured, and other underserved populations are of interest. NINR is uniquely positioned to sponsor this concept, as we are disease and age agnostic, and we're interested in pain management across the lifespan. We're also interested in prevention and management of specific chronic pain conditions, including those listed here and more. In conclusion, this concept addressing chronic pain in rural populations aligns with NINR's guiding principles of advancing health equity and diversity, tackling today's pressing health challenges, and discovering solutions to optimize health across clinical and community settings. It aligns with H.E.A.L goals of improving chronic pain management and appropriate prescribing of analgesics, including opioids, across populations. And it addresses a unique programmatic need, focusing on the challenges of implementation in rural and remote populations, which has not been directly addressed in other H.E.A.L initiatives. Thank you very much.
Thank you for that presentation, Dr. H.E.A.L. We've asked Dr. Lowe and Dr. Stone to help lead us in our discussion on this concept. Please go ahead, Dr. Lowe.
Thank you for that overview and that very insightful and exciting initiative regarding the concept. So the goal of this concept aligns with the H.E.A.L goals and mission and is timely as it responds to the NINR 2022-2026 strategic plan that supports optimizing health and advancing health equity into the future. In particular, there is consistent evidence that racial, ethnic, minority, rural, and remote populations are overrepresented among those who experience chronic pain and whose pain management is inadequate. Rural and remote racial ethnic minorities consistently receive less adequate non-opioid treatment for chronic pain than non-Hispanic whites, even after controlling for age, gender, and pain intensity. Chronic pain underreporting appears to be a major contribution to chronic pain management disparities. Additionally, the major contribution by health providers and systems to such disparities appears to be reflected in the intersection of limited awareness of beliefs and stereotypes regarding the chronic pain experienced by racial, ethnic, minority individuals within rural, remote settings and the use of opioids. As a U grant mechanism, research guided and supported by this concept related to non-opioid chronic pain management among rural and remote populations should aim to address the following questions. Where are we now? Where do we need to go? How do we get there? Specific to these questions, this concept can lead to research that elucidates the following. 1, common challenges encountered in managing chronic pain among rural and remote populations. 2, current evidence pertinent to the presence of rural, racial, ethnic, minority disparities and or inequities in non-opioid chronic pain management and the factors that may contribute to the observed differences. 3, non-opioid pain management goals and interventions that may be relevant within rural and remote settings. And 4, collaborative research, education, and practice strategies that may facilitate the elimination of the rural and remote inequities regarding non-opioid pain. The opportunity to respond.
Thank you, Dr. Lowe. Thank you, Dr. H.E.A.L, for that wonderful presentation. I'm too very excited about this opportunity. I'm especially pleased that this is a collaboration with complementary medicine and looking at other sort of non-opioid interventions. I'm also really pleased that these U grants will sit in the pragmatic trials collaboratory, because I really think this is real world research that needs to go on to really find out what works and what doesn't. We do know that rural care is not as good, that people have, poor access to quality care. And I think, and nurses are one of the largest growing populations of primary care in rural areas. So I'm very pleased that nursing NINR is taking a lead in this, because I think nursing interventions will really be helpful and to get the research out about that. So all in all, I just think the data that you gave was really compelling, and it's a great research concept. So any other comments from anybody else?
Okay. Well, hearing none.
Elizabeth, do you see Sheila's hand?
Oh, no, I'm sorry.
That's
Dr.
okay.
Sullivan.
Thank you. Good afternoon, colleagues. I do have a question. Obviously, I'm from the Department of Veterans Affairs, so I have great interest in knowing whether you guys are identifying military service, whether current or past, as part of the data that you collect, and how you are looking at those situations differently, because especially in those rural communities, veterans health care. I mean, we can't build a clinic on every corner, right? So we're relying heavily on community care, but veterans' needs are different and specific. So I was wondering if you could address how you're addressing those concerns. Thank you.
That is a fantastic question. And obviously with an initiative like this, much of it will depend on what individual investigators are focusing on. And in this case, what's pertinent to the individual communities that they're working with. Because that certainly is more true in some rural communities than it is in others. It is very much something, though, that overall H.E.A.L has been interested in and collecting data on. So it is very much something that we can add in some encouragement, just as we are encouraging investigators to collect enough data on different racial ethnic groups, on different sex gender groups, so that they can aggregate data. We can certainly add that in. Thank you for this suggestion.
Any other questions or comments? Okay, well, hearing none, thank you, Dr. Lowe and Dr. Stone, for that discussion, which will help us move this important concept forward. And Dr. Zank, I turn it back to you.
Thank you, Elizabeth. Thank you, everyone. It's great to have that concept moving forward. So thank you, Karen, for your leadership on that as well. So I see Dr. Murray is here, so we will turn to our next agenda item. So our next presentation is by Dr. David Murray from the NIH Office of Disease Prevention. So welcome, Dr. Murray. So Dr. Murray was appointed Associate Director for Prevention and Director of the Office of Disease Prevention on July 2nd, 2012. Dr. Murray has over 40 years of experience in disease prevention research and has helped the Office of Disease Prevention work towards its mission, which is to work with NIH institutes and centers and other partners to provide leadership and direction for the development, refinement, implementation, and coordination of a trans NIH plan to increase the scope, quality, dissemination, and impact of NIH disease prevention and health promotion research. So welcome, Dr. Murray.
Thank you, Dr. Zink, very much. I'm very glad to be here. I'm going to share my screen so that people can see the slides that I'm going to work from today. Now they should be visible to you. And
they are. Thank you.
Yes, thank you. You've actually given my first slide, so thank you for describing the mission of the office and the role that we play here at NIH. We're a small office. We're in the office of the director. We're not focused on any particular disease or risk factor. We work with all of the institutes and centers. And in fact, we wouldn't accomplish much if it weren't for all the collaboration that we have with the institutes and centers, including NINR. Everything that we do is drawn from our strategic plan. And the 6 priorities that we've had in that plan for some years now are shown on the left side. We focus on portfolio analysis. We try to identify research gaps in prevention. We try to promote the use of the best methods in the prevention research that NIH supports. We certainly try to stimulate collaborative research across the institutes and centers. We have a strong group focused on tobacco regulatory science, working with our partners at FDA. We have a communications group. And we've had 3 cross-cutting themes shown on the red stripe in the middle. We are particularly interested in the leading causes and risk factors for premature death and disability. We're particularly interested in health disparities, and we're interested in dissemination and implementation research. Now, something that happened late last year was that our cross-cutting theme for health disparities was elevated to a new strategic priority effective this year. Dr. Collins approved that on his next to last day at NIH, and I'm grateful that he signed off on that before he left. Portfolio analysis has certainly been one of our priorities from the very beginning. We're interested in particularly primary and secondary prevention in humans, along with relevant methods work. We define prevention to include efforts to promote health, to prevent onset of disease, disorders, conditions, and to detect and prevent progression of asymptomatic disease. And there's a list of the kinds of things that we include shown here. We have a team of coders who manually code research projects that are either submitted to NIH or funded by NIH. We focus both on applications and awards. They focus on a number of topics or aspects of the research related to the focus, related to the population, related to study design and purpose, related to the type of prevention that it is. Within focus, we code rationale, exposures, and outcomes. We code over 140 topics. It's actually more than 29 pages now, the protocol. We've had input and guidance from our Prevention Research Coordinating Committee, and NINR is a member of that committee. We have masters in public health students who do the coding for us. They go through a couple of months of training before that we turn them loose. They code in 3-person teams. We've determined that team coding works much better than individual coding. We code awards and applications in all of the activity codes that are used by NIH for research, though we focus primarily on 12 that represent most of the prevention research at NIH. The inter-rater agreement among the coders has held at 0.85 since we started doing this work. This slide is the first data slide, so I'll take a moment to walk you through this. So what we're looking at is the percentage of new research projects funded by NIH using one of 12 activity codes that cover almost all of the prevention research at NIH. This gives you an idea of how much of NIH's portfolio is focused on prevention. When I got here, it was about 17%. I was disappointed in the first several years that I was here to see it declining down to 15% by the time we got to 2016. But there's been a nice rebound, and it's grown now to 24.4% in 2020. We code every year. We're in the midst of coding FY21 now. So we'll have another data point in another 6 months or so. I'm not showing the figure for dollars, but it follows very closely the pattern that you see here for projects. The percentages are a little higher for dollars because prevention research tends to be more expensive than basic research. This is a look at how much we're putting into research, prevention research on the leading risk factors for death. And what you see is about 32% of the NIH prevention projects address any of the top or leading risk factors for death. But then when you break it down into individual risk factors, the fractions are much smaller. The numbers have been declining for tobacco and alcohol and multiple risk factors. They've been flat for the other topics. In terms of designs that are used in prevention research, this is of considerable interest to me. I'm a methodologist at heart. I continue to be surprised that most prevention research supported by NIH employs an observational study design. We know a heck of a lot about the leading risk factors and causes of death, and I would like to see a lot more research in using randomized interventions or non-randomized interventions. But to date, it's still very high, concentrated on observational studies, analysis of existing data, which is going up. Randomized interventions are in 4th place and going down. So it's actually about 12% in 2022. The 17% figure that you see there is an average. So I'm concerned that we have so much of the prevention budget still going into observational studies and secondary data analysis, and a declining fraction in randomized interventions, which I think should be a larger part of our work. We've been particularly interested in finding out how are we doing in terms of health disparities research. The top line shows the fraction for all of NIH that's focused on the leading risk factors for death in all populations. And as we saw 2 slides ago, the average is in the 32-33% range with a slight decline from 2016 to 2020. But if we start to look at the health disparities populations, the fractions are much smaller. Only about a third of that goes into health disparities populations, research of any kind on the risk factors. And if we look at the interventions for the leading risk factors for death and disability in health disparities populations, it's an even smaller fraction, less than 4% in 2020. That's a very concerning figure to me. When we look at the individual risk factors, it's actually more distressing. The overall number itself is quite low, as I said, under 5% and going down. And if you look at any of the individual risk factors, most of them are declining, shown in red. Tobacco, alcohol, drug use have been stable, not declining or increasing, but many of them have been declining. That led my office, led me to propose an initiative that we call ADVANCE, Advancing Prevention Research for Health Equity is the full name. I started discussing these findings with the institutes and centers and offices across the campus in 2020, late that year, and talking with them about their interest in a new initiative to promote prevention intervention research in health disparities populations. I presented this to the IC directors a little over a year ago. There was broad support, and 24 of the institute centers and offices have agreed to participate in planning discussions, including NINR, and those discussions are underway now. We've identified 4 work groups that we have now constituted: cardiometabolic, cancer, alcohol, tobacco, and other drugs, and mental health, shown on the right side of this slide. Each of these work groups is co-chaired by a member of my team and 1 or more representatives from lead ICOs working in that area. So no surprise, cancer takes a lead role in the cancer area. NHLBI takes a lead role in cardiometabolic, and so forth. The work groups are thinking broadly about what kind of research is needed to address the leading risk factors, what kind of intervention research in health disparities populations. They don't have to focus on the top 10. They can go more broadly than that. They can decide whether they want to pursue additional portfolio analysis or RFIs or meta-analyses and so forth as preliminary activities. Their job is to develop FOAs. That's the product that we hope to see coming out of this. And we hope to start seeing FOAs coming out next year. Later this year. The focus is on populations experiencing health disparities, and NIH identifies several: racial, ethnic minorities, sexual and gender minorities, socioeconomically disadvantaged populations, underserved rural populations. The emphasis is on prospective preventive interventions. They could be testing new interventions or testing new strategies to implement, disseminate existing interventions. I anticipate that the work will support both randomized trials and non-randomized trials. We can have strong research using all of those methods. Now let me turn a little bit to our examination of the portfolio that NINR holds in the prevention world. And what you see here is the same kind of figure that I showed you earlier for NIH as a whole, but this is for NINR. Running from 2012 to 2020. We didn't analyze as many projects within NINR as we did for NIH as a whole. NINR is one of the ICOs that was included in the larger portfolio analysis. And what that means is that the confidence bounds are much wider for a single institute than for NIH as a whole, but the point estimates are still valid. What we see with the NINR portfolio is a lot of variability. With very high levels of support for prevention research in some years and much lower levels of support for prevention research in other years. But quite generally, it's been higher than NIH as a whole, and certainly the last few years, it's been appreciably higher than NIH as a whole. If we look at the leading risk factors for death and disability in the NINR portfolio, we see increasing support for many of these risk factors, the ones shown in green. So increasing support for any leading risk factor, increasing support for multiple risk factors, increasing support for work on blood pressure, dietary risk, BMI, high total cholesterol, low physical activity. There were a few that showed declining levels, tobacco, alcohol, drug use, but I know that that is because we have institutes at NIH that are focused on those topics. And so NINR defers in part to NCI on tobacco, in part to NIAAA on alcohol, in part to NIDA on drug use, and in part to NIDDK for impaired kidney function, and is very active in the other areas, and we're grateful for that. When we look at the research designs that NINR uses in its prevention portfolio, I'm delighted to see what a large fraction is represented by randomized interventions. That's what I'd like to see across NIH as a whole. So thank you, NINR, for leading the way. And I point to you as an example for the other institutes and centers that it's possible to do this. We don't have to put 2/3 of our portfolio into observational studies. NINR still has a substantial observational portfolio, but it's not as large as NIH as a whole. And it is possible to have a much larger fraction in randomized interventions, as NINR does. When we look at the leading risk factors with health disparities populations, again, we see a very encouraging pattern for NINR, with most of these increasing, all the ones shown in green. The others are stable. They're not going down, but they're not going up. And again, the ones that are stable are the ones where NINR defers in substantial measure to other institutes and centers that have that content area as a feature in their portfolio. So again, congratulations to NINR for all of the great work that's going on in prevention research addressing the leading risk factors, particularly intervention research addressing the leading risk factors in health disparities populations. It's a low figure for NIH as a whole, but without NINR's support, it would be far lower. So this summary of the material that I've just rather quickly run through, prevention research represents about 1/4 of the research funded by NINH, but it represents about 3/4 the projects funded by NINR, certainly in 2020. So quite a bit of separation there. We're appreciative to all of the prevention work that NINR supports. Intervention research addressing the leading risk factors for death and disability in health disparities populations is under 4% for NIH as a whole, but it's over 17% for NINR. Again, a great showing, and we hope that with the ADVANCE initiative, we'll see greater investment from the other institutes and centers and offices trying to catch up to NINR. ADVANCE is a new initiative. The work groups are currently meeting. I hope that we can see some new FOAs released before the end of the calendar year. We've got one NOCI that's in the system already, not published yet, but hope it will be out soon. We have 4 work groups. NINR is very active on 3 of those. So again, congratulations. I will note that NINR and ODP collaborate on other activities as well. They've been very helpful to us in identifying candidates for the U.S. Preventive Services Task Force, including someone who was appointed recently, who's a former doctoral student of mine many years ago at the University of Minnesota. We work together on health and housing issues. We work on a number of prevention scientific interest groups and other trans-NIH funding opportunities. It's been great for me, for Dr. Zink to join NIH to lead NINR, and I'm looking forward to continuing to work together towards improving prevention research that NIH supports. So that is the end of my formal remarks, and I'm happy to take questions. Dr. Zink, from you or from others listening today.
Thank you, Dr. Murray. David, so appreciate your leadership and your partnership in prevention research, and we're looking forward to many more opportunities to work together. So we've asked Dr. Holmbeck to start us out with the discussion. So Grayson, if you're on, it's all you.
Thanks a lot. You can hear me okay, right?
Yes.
Yes.
Okay. That was really interesting. As we just heard, the goal of the Office of Disease Prevention, ODP, is to increase the impact and dissemination of prevention-oriented research. And it's very exciting that such a high proportion of funded research is in the areas of primary and secondary prevention. And the ODP has several promising strategic priorities that Dr. Murray discussed, including the important new one, minority health and health disparities. And one focus of his talk that he just presented was their portfolio analysis. And they developed a very sophisticated, high reliability coding system. And I just had a few comments about the taxonomy, if I could.
Sure.
As a psychologist, pardon?
Sure, absolutely, go ahead.
Oh, sure. As a psychologist, I see mental health as a very broad category that could be broken into several subcategories. And each of these subcategories would require, I think, different kinds of prevention intervention approaches. And also, some of the mental health outcomes in the taxonomy are, I would call them mental health outcomes. They're included as their own categories: suicide, alcohol, tobacco use, substance use, and so on. And also, I thought of some other areas that could have been included, but anybody can say this, of course. And you have a coding system you're using over time, so I'm sure it's very complicated to revise it. But sleep problems, racial discrimination, excessive use of social media, video gaming, COVID-related outcomes, and so on. I assume these are probably topics of other proposals that would have prevention implications. With respect to identifying risk factors, I was wondering if studies focusing on psychology relevant health promotion and risk factors are included in the system, such as research focused on vaccine hesitancy or psychological challenges to medical adherence or use of prenatal vitamins and whatnot. The graphs you showed were very, really interesting and actually begged some questions, I think, some why questions. Is why the decrease over time in research on tobacco and alcohol, why the decrease in randomized interventions, and then why the decrease in health disparity intervention studies across so many of those areas. And so given that, I saw that slide, and then I was very excited to see the ADVANCE program, advancing research for health equity, across so many institutes, and that NINR is involved in all 4 of the work groups. I was just thinking that before moving forward on health disparity intervention initiatives, maybe answering some of those why questions about why there has been this decrease over time might be of interest. And also in the NINR slide where it was 75.6% it's so high compared to the other institutes. I was wondering, how did they go from 19.4 as recently since 2017? I just found that increase, it's like a 400% increase over 4 years. And then it's very exciting. I thought the most exciting part was at the end when you said about the randomized trial rate of close to 50% for NINR. And I was thinking, and actually you said this, I was thinking that other institutes could maybe learn from NINR about how to increase their percentage as well.
Yeah.
So those are my comments.
Well, thank you for your comments. There's a lot in there to respond to. Certainly, there's an infinite number of topics that we could include in our taxonomy, but a finite number of resources that we have to implement the taxonomy. So if we tried to do a deeper dive in each of the 140 topics that we have now, we'd need a much larger budget. What we've tried to do is get an idea about how much activity there is in each of these 140 areas. And then sometimes we do a deeper dive within one in collaboration, usually with the institutes and centers that work in that area. So we've dug more deeply, for example, into alcohol, tobacco, and other drug use. with NCI, NIDA, NIAAA, and have a paper with a more detailed portfolio analysis in that area. And we can do that in other areas as well. So we've taken that approach rather than trying to expand the taxonomy to include everything, because that's not manageable, to, as there is interest, dive more deeply into some areas. I agree with you that the variability in the numbers that we see for the proportion of prevention research at NINR is striking. That's partly a result of we sample. So we draw a representative sample of projects that our machine learning tools identify as probably prevention. And then we draw a representative sample from projects that machine learning identifies as probably not prevention. And we code the sample, and we then extrapolate back to the whole population of awards. For NINR, the sample is fairly small, which means that the estimates bounce more than they do for NIH as a whole, and it means the confidence intervals are wider. So if we were to back up and look at the NINR slide again, I'm not arguing, oh, the 75% is absolutely the right number, and the 25% is absolutely the right number. There are 95% confidence intervals around those, so that the truth may be closer to the middle in both cases. But certainly the data that we have suggests that NINR is very strong on prevention research, and we're glad for that. I'm very excited about the support provided for randomized interventions. You asked the question, why is it going down in general? I don't have a good answer for that. I've had that conversation with the institute directors at the ICD meeting. I've had it with them one-on-one. Everybody has a different explanation for the trend at their institute. But there's no question that it's been going down. We've seen it not only in our analyses, but we've seen it in reports published by others who have looked at the same issue. That support for clinical trials has been declining in NINH, and support for observational studies and secondary data analyses has been going up. I hope we're going to turn that around, because we're not going to find effective interventions by doing secondary data analysis and observational studies. We need to do the intervention studies, even though they don't always pan out, and even though sometimes they're more expensive. NINR is leading the way, and that's great. What other questions or comments are there? I'm not sure, Dr. Holmbeck, if I answered all the points that you raised, but I tried to address at least some of them.
No, it was great. Your response was really interesting. Thank you.
Any other questions or comments for Dr. Murray?
I have a quick question for you, Dr. Murray. For what you consider prevention research, you had the 12 categories, 12 activities. And are they just related to, prevention of the top risk factors, or?
No, our definition of prevention research includes all primary and secondary prevention research in humans. So it could be research to identify risk factors or protective factors for the onset of a new condition, or it could be research to try to do something to prevent the onset of a new condition. It could be research to identify risk or protective factors for continuation or advancement of an existing condition that hasn't been diagnosed yet, or for addressing those risk factors. So there's a variety of research that can fall into it. It doesn't have to, it's certainly not all intervention research. Much of it is observational. And it doesn't have to do with, it doesn't have to involve the 10 leading risk factors. It can be on any content area. We see only about 30% of the work is focused on the leading risk factors. In 2020, only about 12% involved a randomized intervention. So it really is spread out over a variety of areas. The 12 activity codes that I mentioned, those are things like R01s, R21s, R03s. Those are the activity codes that are used to support the research. And we've identified 12 that account for most of the research that NIH supports. We've always coded those 12. Beginning in 2018, we started coding all of the activity codes. So we were sensitive to the criticism that we got in some quarters that, hey, you left out an activity code that's important to us. So now we do all of them, and that complaint has gone away.
Thank you very much for that clarification.
Anything else? Last chance. Well, David, thank you for joining us today. We
Happy to be here.
Yeah, it's great to have you. We're really excited under the strategic plan that prevention will be a priority and it'll remain so, and building on the strengths we have in that area. So looking forward to working with you and your office. So thanks.
Thank you.
So, all right, we're moving right along today. And we are now at the time to turn the floor over to you, so to speak, and see what questions or comments you have, just in general, about anything you heard today or about anything else. So any comments, announcements, questions you have?
I had one question. Following up on what we just talked about, do you have any sense, Dr. Zank, about how it is that the rates are so different in NINR than versus the rest of NIH in terms of like what's been done that's so successful at keeping the percentage of randomized trials so high?
Yeah, I think it's a great question. I think the Institute has a history of prioritizing intervention research. I think that's been a value for a long time. And so, you know, on the surface, I would say that, you know, could be an explanation for what you see.
Mm-hmm.
Does anyone else have different thoughts or about that, or anything you want to add, Dr. Monroe?
Yeah, I might add that I think it's also sort of a part of the culture of nursing that we tend to think in terms of how to make things better instead of just how to see what's going on. So I think the sort of natural inclination for nursing research tends toward intervention rather than observation as the endpoint. And so I think it is, and I do think NINR has really focused on, you know, what can we do to be helpful, but only how do we understand the underlying problem. So I'd say it's also partly cultural.
Yeah, great addition. I agree. Other announcements or questions or things to add? Pat?
Yeah, I have a question with your, I love the strategic plan, and I really do. And you know, so I'm wondering, one is what NINR has been hearing back from the community, and if anything, you know, I know you had the open comment periods and things, but are you hearing now that it's out, are you hearing anything? And two, do you think, when I look at the strategic plan and the conversation that we're just having about RCTs, I'm not sure that we might put into more health policy research, which will be using national databases for some of the lenses that you're looking at. And has there been any thought about that?
I might not quite caught the end, so let me know if I don't answer that part. So what are we hearing back? Well, I think we've been really pleased at the enthusiasm and the support we've received for the new strategic plan. It's been a lot of hard work from so many across NINR and so many in the nursing science community who have given feedback in a wide variety of ways into the strategic plan. So we are delighted to have it out, and we are very excited about the response we've gotten to the plan. So and we're, you know, really excited to move forward and to advance science in these areas. So we are talking in the Institute about three different ways, types of implementation for the strategic plan. Certainly a main part is on the science and training and really moving that forward. A second really is about communications and outreach and really thinking about how to push that way. And then third is really focused on continuing to build the climate, the environment in the Institute to really be the best institute at NIH in terms of being a place to work and being a good collaborator in a variety of ways across NIH. So we are moving all of those three plans for implementation forward. In terms of policy, right, so, and again, let me know if I don't get this right. We are putting an emphasis on policy, so it is part of the strategic plan. You know, randomized experiments may be possible, quasi-experiments, et cetera, in that space. Certainly natural experiments, so that's possible, but you're right, the design is often different when we start to answer policy questions. So, you know, it could have an effect on the share of randomized controlled trials, but we do know to answer pressing questions, to solve pressing problems, we need to consider a wide variety of study designs, what's most appropriate for the question. And while we continue to value randomized controlled trials, we don't want to be constrained, right, in terms of what questions we're able to answer based on that design alone. We need to be creative in terms of quasi-experimental designs and natural experiments to be able to address the most pressing questions of the day. So I think that'll involve certainly randomized controlled trials and a wide variety of other designs as well.
Thank you so much, Dr. Zhang.
Yeah, thank you, Dr. Stone. Other announcements or questions, Dr. Lowe? Oh, I can't, sorry, can you unmute?
I have an announcement, if it's okay to share.
Terrific.
Yes, we have planned our third International Indigenous Nursing Research Summit, and this will be held and hosted at University of Texas Austin School of Nursing, and that's November the 3rd through the 5th. And this is an event where we are gathering Indigenous nurse researchers from around the globe to come and share the research efforts. And also we are developing and we'll have a platform and a forum where others who are non-Indigenous or non-nurses who would like to come and network and share and opportunities for the work that others are doing, that they would like to connect with Indigenous nurse researchers and to benefit Indigenous communities. So as you know, we are the most underrepresented group in nursing and especially in research. And so this is really an exciting effort to really come together and unify and to share with the world what we're doing, and that we in nursing is so important in the health and especially research in the health of our communities. And so we would like to have everyone come and join us, and the event is posted on the university's website event page. So and if you have any questions or need more information, please feel free to contact me. Thank you.
Thank you, John. Yes, a really important meeting. Thank you for all your work to plan that. Looking forward to that this fall. Thank you. Other announcements, questions or comments? All right. Okay, so that concludes our open session, unless anyone, last chance, wants to jump in. So, okay, so again, thank you everyone for your attention, your feedback, your questions today. So that is going to conclude our open session. So this is 2:31 p.m. Eastern. Hopefully I got the time right this time. So we will now be moving into closed session. So council members, I'm going to ask you to join me for closed session in about 5 minutes. As a reminder, there is a separate meeting invitation that was sent to you with login instructions for that closed session. So you'll need to move in based on that login information. Any questions about that? Okay, so let's reconvene in closed session at 2:36 to be precise, not too precise, 36. Okay. All right, see you all in a bit. Thank you.